Well, thank you for the opportunity to visit with you all. So my talk is about my experience from vision to reality building a comprehensive fetal surgery program at OHSU. So I have a disclosure, I'm a co-founder of OpCon, but it's not related to anything that we're going to be talking about today. These are learning objectives I hope you can take away from at the end of the talk. So to start and set the stage, I just wanted to share my story. So like Raphael said, I graduated from WashU, and my mentor was Dr. Brad Warner, who's a pediatric surgeon. I went there to do research. I stayed there in the lab for 3 years, and unfortunately, he passed away last year. And he mentored a lot of folks. Everyone in this picture is now a practicing pediatric surgeon, including this person right here, Dr. Sandeep Goswami, over here on the right side. He's the surgeon-in-chief at Texas Children's, who later is my mentor. So I matched that at Texas Children's, and that's when I discovered that there's a whole new world of fetal surgery. They have a very large fetal center, and that's when I decided that I was going to stay an extra year after I graduated from pediatric surgery and stay and learn from the maternal fetal medicine specialist how to do fetal diagnosis and intervention. And so at the time in 2020, OHSU in Portland, Oregon, at Better Children's Hospital, they already had a fetal care program. That is, they had the ability to be able to diagnose, counsel, do advanced imaging, and have these multidisciplinary consultations. Along with that, they could do maybe some minimally invasive needle-based procedures. But their vision was to create a comprehensive level 3 fetal center with the L&D, NICU, and pediatric specialists all in one single campus. And so a definition of a fetal center, this was defined by ACOG, which is the American College of Obstetrics and Gynecology, along with AAP, which is the American Academy of Pediatrics. They felt like providing fetal interventions should include a diverse group of individuals and professionals, including maternal fetal medicine specialists, neonatologists, and a variety of other professionals on the team. And so these are the different levels of fetal centers, just like different levels of NICU, the different levels of trauma. The level 3 is the highest level of fetal surgery, which means that you're offering the full spectrum of fetal surgery, including exits, which is extra-utero treatment, which means you're on fetal bypass still, and then you're doing some sort of interventions to secure most likely the airway, and then cutting off the bypass. So that's very basic compared to the needle-based procedures. So that was their goal, was to be able to create a level 3 fetal center. So I just wanted to show you a map of what the current status is for fetal centers. This is the North American Fetal Therapy Network, which is about 50 centers now, 52 centers. And they're all pretty much a variety of level 1, 2, and 3. But the highest level, which means that they provide all services, there's probably about 8 to 10. I made this slide a few years ago, probably about 12 now, that offers the tracheocclusion for the controlled diaphragmatic hernias. And so there's not that many of them across the country. And so when I was looking at this job, I looked at the market, and I really saw a lot of potential. Because at this time, Seattle Children's had 2 MFMs that did some laser surgery for TTS, which I'll talk a little bit about. But they weren't able to provide the full gamut. And so with the birth rates and the target market of the Pacific Northwest, I thought that this was a really good opportunity. But I'll be honest, that wasn't my first choice. It was during COVID. I didn't really want to take on a job as a junior attending coming out of fellowship to start a brand new program, right? That's kind of high risk. But it just happened to be that way with COVID and funding with different other institutions that I landed at OHSU. And so we expanded because at the end of 2020, they were really searching for the fetal surgeon, and they just happened to find an MFM counterpart for me, along with myself, and we were both recruited. We started in 2021. And so this is where MFM, Women and Children's, have Crossroads. We offer all the subspecialties, and we're able to do this all under one institution, a single campus. So when fetus neonate delivers, then they're transported down the hall to the NICU. So it's very convenient. And that's probably the most important logistic structure that you need in order to be able to do all of these interventions. You have to have a place for the mother to be able to deliver in case anything happens after surgery. And so what is fetal surgery? It's a new and emerging field. It's a procedure performed on the developing fetus in uterus to help improve the long-term outcomes of children with specific congenital anomalies. And if left untreated, you could either lose the entire pregnancy or have worse outcomes. So we consider Michael Harrison, he was a pediatric surgeon, he's professor emeritus of UCSF. We consider him the father of fetal surgery here in North America. And luckily, he came as a visiting professor a few years ago. I was able to take pictures with him. I still communicate with him every once in a while. And those of you who have time, you can look on Netflix. There is a documentary called The Surgeon's Cut, and they have 4 episodes, and one of the episodes features fetal surgery. But again, what is fetal surgery? So I like to think of this in 2 large buckets. One is open surgery, the other is minimally invasive. So when Dr. Harrison first started doing fetal surgery at UCSF, a large part of it was the exits, which right here you can see there's a large neck mass. Potentially they don't have an airway at birth. And so while they're on placental bypass still connected to the mother, they'll secure the airway in a way, either through advanced intubation or sometimes even a trachea, and then a tracheostomy. And then once they secure the airway, then they'll disconnect from the placenta. Here, there's another photo of an open fetal surgery. So there's like a large tumor. This is sacrococcygeal teratoma. It's causing a lot of vascular shunting, causing high drops. It would partially deliver the fetus, do the bulking section, put the fetus back in utero, close the hysterectomy, and allow them to continue on with pregnancy. But now we've done a little bit less of the exits and open surgery. We're doing more in minimally invasive surgery. So that's fetoscopy, using a scope, doing interventions that way. And there's a lot of ultrasound-guided needle-based procedures that we can do as well. So these are the conditions that we treat. These are the more common procedures that we do. One of the more common things we do is alloimmunizations, transfusion. So if they're having maternal antibodies attacking the fetal hemoglobin, they can get anemic, they can get really sick. And so we can do transfusions by drawing blood out of the umbilical cord, seeing what the hemoglobin is, and transfusing them every 2 or 3 weeks so that they can get to birth. There is congenital lung malformations that we talked about earlier, and twin-to-twin transfusion syndrome. So what I'm going to do is I'm going to talk 3 things today. They're supported by level 1 evidence, randomized controlled trials. First is twin-to-twin transfusion syndrome. Second is myelomeningocele. Third is congenital diaphragmatic hernia. Fetal. All right, so twin-twin transfusion syndrome. This happens in about 10 to 15% of monochorionic diamniotic twins, identical twins. So they're sharing 1 placenta and 2 amniotic sacs. And what happens during 16 to 26 weeks is there's a phenomenon where there's an imbalance of the blood flow. So then one becomes the recipient, where more blood is being shunted from the donor. And so every placenta has these vascular connections on them. They can be vein to vein, artery to artery, vein to artery, artery to vein. And it's the imbalance of that blood flow that causes this phenomenon of twin transfusions. And so that phenomenon can progress and get twins really sick, and they can lose the entire pregnancy. So these are the different stages of twin transfusion syndrome. So imagine if your heart is pumping, usually we pump 5 liters of blood a minute, but imagine if your heart has to pump like 10 liters a minute. Then you're going to start, developing cardiac failure and things like that. So that's the progression of this for the recipient twin. And so stage 1 is when they become polyhydramnios because they're seeing so much fluid, just seeing so much volume, they're making more urine. And amniotic fluid is essentially urine. So they're swallowing that and they're peeing it out. And so they become more polyhydramnios, where the deepest birth pocket is greater than 8 centimeters. And vice versa for the donor. The donor is not seeing a whole lot of volume, so it's getting less urine output, and that becomes less than 2 centimeters. So you have a discrepancy in different sacs in terms of volume. Stage 2 is when they get more progressive, where you don't see a bladder in your lungs. And stage 3 is when you start seeing the Doppler abnormalities. Stage 4 is high drops, essentially like signs of cardiac failure. And stage 5 is demise of lungs. And so this is an image of stage 1. See so much fluid in one pocket. There's a large bladder, but over here in twin B, there's not a whole lot of fluid. This is the membrane right here, so less than 2 centimeters. Stage 2 is when they progress and you don't see a bladder anymore, and you still don't have a lot of fluid. And this twin is stuck. It used to be called stuck twin syndrome. So there's not a lot of fluid, so the membrane's wrapping around them, and there's defined gravity there. Stage 3 is when they start having Doppler abnormalities. Stage 4, you can see that the skin is thick. There's a little bit of pleural effusion, and so it's hydropic. And stage 5 is and so without any treatment, 90% of the time they would lose the entire pregnancy. There was really nothing to do about 4 years ago. But now there are options. And so when we counsel them, I tell them, one, you can have expectant management where you continue on with pregnancy and see if it progresses and how fast it progresses. In Oregon, they do have the right to terminate. We can also offer them pseudoambient reduction where you're taking out the fluid from the recipient sac. But likely that fluid will come back. Maybe sometimes it doesn't, but most of the time it does because the underlying process is still there. Those vascular connections still exist. And so many moms come to our center as they are seeking for that laser surgery. We're ablating those vascular connections so that we're separating them to two separate centers where they have their individual blood flow. And in port occlusion is where we intentionally port occlude the donor usually in order to save the recipient. And so they did a randomized control trial where they looked at ambient reduction versus laser surgery. And what they found was that laser surgery was by far the better option for outcomes. And so now that has really become the standard for those that want to try to save both twins. They will want to have laser surgery for that. And so this technique, we put a really small scope through the uterus, which is the amniotic sac, identify those vessels, and these vessels are tiny. Like I said, every placenta has these vascular connections. It's when they have the imbalance of the blood flow that causes this TTS. But here you can see the stars, those are the vascular connections, and so our goal is to identify every single vessel using the scope and laser ablate them. So I'm going to show you a video. I don't know if this video will work. Okay. So this is a cartoon version, and I'm going to fast forward through this. But basically it's showing that the recipient's bladder is getting larger, and it's pushing the membrane onto the donor because the donor is not getting nearly as much volume. And so, again, big bladder, this vertical pocket is greater than 8 centimeters, and that's when we use ultrasound and fetoscopic guidance to be able to identify these vessels. And when we see these vessels, we have to be sure that they are truly the recipient to the donor, or the donor to the recipient, because sometimes these vessels will loop back to itself, and it's actually the recipient's vessel all along. And so this is what it looks like on a cartoon, but this is what it looks like in real life. So those of us that do laparoscopic surgery, you're using sometimes like a 4 or 5 millimeter scope. This is a 2 millimeter scope, so your scope of view is much, much smaller. So there's particulate matter, you have narrow scope of view, and so it can be really challenging. But you can see that these are the vascular connections. Over here on the left, you can see the membrane of the donor. And so generally you use that to guide where the vessels are. But you can see that these are the tiny vessels that are the vascular connections causing this. And like I said, it's really important to get all of these vessels, because if you leave one that's not in favor of one or the other, then they can either have ongoing TTS or they can have reverse TTS and switch roles. And so it's really important to get all the vessels. And what I do here is it's called solemnization, where you connect all these vascular connections from one end of the sun to the other. Now that I've been out for a few years, I'm very selective on the solemnization because I do think that there may be an slight increase of placental eruption. And so what I'm doing is I'm ablating this and connecting them. Now I'm really confident on these vessels that I ablate, that if I don't see another vessel in between, I don't necessarily buzz the placenta. And so that sounds good and all, but the outcomes aren't perfect. So when we talk to the mothers, we say that the chance of having one twin survive is about 85%, 90% in all stages. And if you want to have 2 twins, usually as a donor to the demise, but if you want to have 2 twins that survive, then that chance is about 65, 70%, 75%. But if you get to stage 3, stage 4, that's about 50, 60%. And oftentimes, if there's growth restriction on top of that, then that chance of having dual survival. And so these procedures are really humbling. Each case is very challenging, and there are risks involved. These are the risks. anytime you put an instrument through the amniotic sac, through the uterus, like you have a hole in it, that hole doesn't close, and so there's a high chance of membrane separation, which leads to bringing back water to preterm delivery. And so the amniotic sac is not like any other part of our body. We have a cut in our body. We have platelets and clotting factors and fibroblasts that heal. There's no such thing in the amniotic sac. There's just a hole there. And so that membrane separation of fluid is real. And so we worry about that. So we always have to weigh risk and benefits when we're talking about laser surgery, laser intervention. So there is a chance that even after a successful surgery, they can potentially still lose the entire piece. Because again, this intervention happens usually about 16 to 26 weeks. So most of the time, they're premature, not viable. But unfortunately for us, we started doing laser surgery about a year when I got to OHSU, and we've been able to find a lot of success, a lot of families, a lot of twins, and mothers are very excited to bring back their twins back to our clinic and say hi to us. So it's been a wonderful experience. So after we did that for about a year, then we started to say, okay, now we're ready to do the next step, which was myelomeningocele. And so myelomeningocele is really a neurologic issue that pediatric surgeons deal with, otherwise known as spinal bifida. But essentially, it's a spinal cord that's exposed. And so it happens about 2 to 3.4 per 1,000 live births, despite the use of folic acid. And it occurs about 1,500 cases. And so we think that there's a two-hit hypothesis to this. One is there's the failure of the closure, failure of neurology, but also the exposure to the amniotic fluid that has ongoing inflammation and can cause inflammation of the spine. And so there's a lot of clinical significance to this. The lower extremity weakness and paralysis affects motor function. There's such a thing as the neurogenic bladder, the neurogenic bowel. They can develop hydrocephalus in the brain where they may need a VP shunt by our neurosurgeons. And there's still a pretty high mortality. And so in the 90s, they started doing animal studies on sheep, and they thought that might be a way to be able to help these fetuses even before. And so that's what led to this famous long-term management of MMC study. This was 3 institutions across the country, UCSF, Vanderbilt, and Children's Hospital of Philadelphia. What they did was they randomized moms with this diagnosis of myelomeningocele, and they put them into 2 arms, postnatal surgical repair, which is the standard, and then fixing everything. So it initially started with a hysterotomy. So again, like the open surgery, they exteriorize the uterus, make a small incision, further have the neurosurgeons repair, close up the hysterotomy, and then let the continue on with pregnancy. But all of these mothers had to have a C-section because of this large incision. And so, but they found great outcomes. They saw that there was a decreased risk of death or need for shunting at 12 months. The need for a shunt decreased by half. It was 82%, and now it's 40%. And the other thing that was really profound was that the motor function improved. And so the likelihood of walking independently doubled. So it went from 21% to 42%. And so that's when fetal centers started offering this more. But there are risks that we do. There's risks. There's risk for the mother. There's risk for the fetus. And you have to keep in mind that this is very different than the previous surgery that I talked about for laser surgery. 90% of the time, if you don't do laser surgery, it's pregnancy. Here, if you don't do anything, it's okay. They still have the option of having surgical repair, which is the standard. So this is very elective. And so they really have to understand that, yes, it could potentially improve their outcomes, but there are risks, and it's not 100% guaranteed, and it's not a cure for myelomeningocele. It's just a way to be able to improve those outcomes that we talked about. And so then people started doing minimally invasive. So instead of that large hysterotomy, fetus got small incisions on the uterus. And what they found, these are different techniques. We do the laparotomy assisted, which is exteriorizing the uterus, putting small incisions through the uterus, and being able to attack the membrane so that we decrease that risk of membrane separation. What they found was like the outcomes of the fetoscopic repair was the same as the open repair. Same outcomes at 12 months, but the rate of having a C-section is much lower. These mothers can have vaginal delivery because of those small savings on uterus. And so for us, we offered minimally invasive, either laparoscopy assisted where we exteriorize the entire uterus, or percutaneous mini laparoscopy where a small incision. Either way, it's minimally invasive. And so our care team is really large, a lot of stakeholders involved in this type of case. And so our milestones is the first thing we did was we got FDA and IRB. Now, many institutions across the country don't do that. But for us, because we were junior faculty, and for me, I was just like, I don't want to go to an institution and offer this brand new procedure and not have any oversight. I wanted to be transparent, I wanted to be intentional. And so we took a year to get the FDA and IRB approved so that we can prospectively collect data and track our outcomes. We provided simulations for our pediatric neurosurgeons because they aren't used to laparoscopic surgery. So it took some while to train them on it. And we allowed them to have some off-site training for them to visit my previous fellowship at Texas Children's to be able to see what their pediatric neurosurgeons were doing. And then credentialing those mentors from Texas Children's to come over to my institution at OHSU to proctor my first 5 cases. And so these are the simulations that we did. These models are actually fairly inexpensive. They're about $30,000, so it's really easy for our institution to purchase that. These are our pediatric neurosurgeons in our practice suturing, dissection, and laparoscopically. And we have simulation with our anesthesia. So we have OB anesthesia along with pediatric anesthesia. And so we really have essentially 2 teams, one for the mother and one for the fetus. And so then these are some images for fetoscopic surgery. This is what a myelin looks like. Essentially, it is like laparoscopic surgery when it's like uterus with CO2. And so I just wanted to share with you, this is our first patient that decided to trust our team in doing a myelin repair. And so she got interviewed with the local news. I guess we have some audio issues, so I'll try this.
We were going for our 5-month checkup. We went in thinking everything was good. We're just going to check up on baby. We were really excited.
Vanessa recalls the ultrasound tech looking at a specific spot over and over again during her appointment. That's when the doctor came in and shared the news.
So she kind of just said, your baby has spina bifida. This is what we think it is.
Spina bifida is a birth defect that occurs when the spine doesn't close properly during the first months of pregnancy. Surgery often takes place days after the baby is born and can come with lifelong medical problems and mobility function issues. But doctors offered an alternative, surgery inside the womb.
I didn't think twice to make the decision to do the surgery.
At just 26 weeks, the couple took the leap of faith in April and said yes to surgery.
Yeah, so she was our first patient. And that was in April of 2024. We became the first program in the Pacific Northwest to offer this. And you can see how large the team this was. This is the first case. I had my mentors from Texas Children's fly in. They got licensed, credentialed, and they did the first case and proctored us. And so that included our MFM, their pediatric neurosurgeon, their pediatric anesthesiologist, who's also boarded in me. So we had our guests. Again, such a large team there. So these are some of the images from that case. But this is what it looks like in utero, large myelomeningocele with a black coat and a sac. And so that's what it looks like afterwards. So when they're born, that's what it looks like. It's all healed. Sutures are pretty much all dissolved. It's PDS that we use. And this child is doing wonderful right now. So we're able to take some pictures of them. And this was another case. The mom was so excited to send us. They turned 1 year old, and it's hard to predict whether they are going to be able to walk or not, but she was just so excited because this child was able to show signs of being able to use their legs. So they were super excited to send us this video. And so the last thing I'll talk about is congenital diaphragmatic hernia. Dr. Espinosa did a wonderful job actually going through this, so I can probably speak through some of these things, but essentially there's three issues with CPH. One is pulmonary hyperplasia, pulmonary hypertension, and cardiac arrest. And so, like she said, LHR, so the lung to head ratio. So we usually measure the contralateral lung, but in this case that you presented, the right side of CPAM probably distorted that a little bit. But there's really not a whole lot of things that we can do to predict the outcomes of CPH. But lung to head ratio is one of them. So I remember one as a cutoff. Usually anything greater than a one does pretty well. Anything less than one, usually not so. And that's usually an ultrasound measurement. Then there's volume measurement by an MRI as well. And then there's liver herniation. If the liver is up, generally does worse in pretty much every single category. So you can see here, depending on the observed to expected lung to head ratio, every single category with the liver up does worse than the liver down, except greater than 46%. Irrespective, that's at that point, it's irrespective of the position. Generally, those units do. And so, yes, we offer fetoscopic tracheal occlusion where we're putting in a balloon. And this is actually really interesting. There's a disease called CHAOS, CHAOS, that stands for congenital high airway obstructions. And those babies have like some sort of atretic trachea or web, and they keep a lot of that pulmonary amniotic fluid in their lungs. And so Michael Harrison, that father of fetal surgery, thought, man, like those lungs are so massive on this CHAOS patient. Why not clip the trachea or the trachea? And that's how actually this got started. And so Yonda Press was one of the leaders of this fetal trial that he presented. And this balloon is super tiny. You have to use hoops and set it up. And it fills like 1 cc of fluid. So that's what it looks like. You put the balloon inside the trachea right above the groin, and you leave it there. So using ultrasound guidance, you have to first position the fetus in a way that's amenable to this procedure. So if they're face down, their back is, you can't get to it. You have to have a good MFM for the baby so that the mouth, you can see that the mouth and the nose is facing up. So using cell linear technique, you see a wire right there, we put in a troll bar to access into the uterine cavity. Then once you do, again, the scope is super small. But basically, what I wanted to show was that balloon right above the corona. You can see it inflate in the corona. And it's a very small scope, and it's about 2 millimeters. Some of the newer scopes that we got, it's like 3.3 millimeters. So you only have one instrument to intubate the fetus, so that can be really challenging. But it's a curved scope, so it makes it a little bit easier, but it's still technically challenging. And so, again, my fellowship was one of the institutions that did FETO, and they published their outcomes. And you can see here that before and after FETO, they looked at their lung to head ratio, they looked at the observed expected lung to head ratio, lung volume. And in each of those categories, they improved after 46 weeks after treatment. And they also saw benefit in survival. So these are, you have to be selected in these kind of patients. They're very severe. Because the severe group has a much higher mortality than the moderate version. So when they looked at the moderate, they actually didn't see a whole lot of survival benefit. But like Dr. Espinosa showed, that the severe was the one that is best in terms of like improving survival to discharge from the NICU. That's why those are the patients that we're seeing to do this high risk procedure. Because if you can imagine a treatment in the fetus, and then if the lung goes into labor, the emergent actions that you have to take to be able to inflate the balloon and put it in. So it also takes the village in order to like accomplish this procedure. And so, in closing, I'm going to share with you, the OHSU experience. For us, we were able to build out a comprehensive maternal fetal center. We were able to actually write it up. We're invited by one of the journals to write our experience of it. And along the way, there's a lot of challenges. It wasn't easy. It took a village. It took a lot of stakeholders from multiple departments to be able to integrate and to be able to learn these techniques and the reasons why we're offering this to clients. And so there's a lot of lessons learned along the way, but it takes interdisciplinary collaboration in order to do this. Before I came, there was, the ability to do prenatal consults, the diagnosis. We had advanced imaging, echo, MRI, and ultrasound, and they were able to deliver at our institution. But once we added fetal intervention, we wanted to do more research on our fetal intervention and wanted to expand our innovation to be able to develop new techniques and devices to improve our outcomes. And so when you're looking at building a program, these are the themes that we consider. All of these patients are complex. You have to plan for complexity. We are in the business of rare diseases. Pediatric surgery is the business of rare diseases, and fetal surgery is even more rare. And so it's very complex, and each patient that's complex takes a lot of planning because there's so many disciplines involved. Decision-making capacity, again, it's multidisciplinary. There's a lot of team building and communication across multiple teams. And so this is the growth at our institution. There was an 80% increase in complex multiple. So these twins, these triplets, we started seeing more of these. There's a 20% increase in our patient volume, 10% increase in NICU admissions. Our NICU is almost always full. And in 2026, we're on track to see 550 patients deliver more than 250 babies, 70% requiring NICU, and then the 250 babies coming through the field. We have much more deliveries, just overall, and then perform nearly 50 interventions. And so our referral pattern increased over the last 4 years. The patients that we see have increased as well. Again, the complex multiples have increased. So even though we're not doing laser surgery for every single one of them, a lot of them don't need surgery for twin transfusions. We're just seeing a lot more complex multiples. Our patient encounters, and so from a financial standpoint, like for getting more imaging done, there's more consultations and more clinic visits across the board. And again, our deliveries and admissions have increased as well. So it funnels just more referrals and admissions, and again, the NICU is constantly full. So there's a lot of downstream benefits for building a fetal intervention. So the future growth, I hope that Door by Earth will continue to expand. We're pretty limited with our space in the NICU. We're able to have 50 patients, and oftentimes we may have to transfer out some current patients and we're going to take on new patients. And so there's a lot of strategic planning amongst all the different hospitals in Portland. And I would love to have a dedicated field OR. And then research, developing research in all aspects. A lot of it is to do with collaboration with NAFTA, which is American Therapy Network. And so in closing, I just wanted to close, for the residents, you may or may not, end up building a program, whatever your career aspirations are. These are the lessons that I learned. Okay, mentorship. At the beginning, I talked to you about my mentor, Dr. Brad Warner, and then now I have other mentors along the way. Some of these mentors that have mentored me along the way have not personally worked with me clinically, but it's just that I worked with them, or I knew them across the country, or on my interview path, and they've been able to mentor me throughout my career. And I think it's so important to be able to find those mentors because he is the reason Dr. Warner was the reason that teamwork. All this stuff that we're doing here in Portland, Oregon, it sounds great and everything, but it took a village. It took a village. There's a lot of stakeholders, a lot of people. This is not a one-man show. This is many, many people, probably hundreds of people working together to be able to accomplish each of these pursuits. Growth takes time. There have been colleagues of mine across the country that I've seen go to an institution. They try really hard to build up a program really fast. And I've seen it rise and fall really quickly as well. So growth takes time. You have to be patient. Whatever you're trying to do, growth takes time. Avoid the rat race. Oftentimes I go to national conferences, and I'm seeing my colleagues, and I feel like, wow, they did some great things. But likewise, they're saying the same thing to me. But there's a rat race in academic medicine. And whatever that is for you, your career endeavors, I would just say, avoid the rat race. Do what you want to do in your career, and then enjoy the process. And then last is to prioritize your life, your health, your family, your friends. Prioritize that. Work is work. It's always going to be there. And I'm not saying don't work hard. Work hard, but still make the priorities count. And so just, I couldn't have done it without my family. It's a long training process, like all of us that have gone through it. But for me, my wife really supported me throughout this entire process. They couldn't have done it without her. So I'll conclude with that, and I'm happy to take any questions.
Yeah, we have a history here with giving a lot of credit to Dr. Wangenstein for setting up an environment for Seawalt Little High and others to move forward with cross circulation and open heart surgery. And now I wonder, with the presence of John Hunter, his early work as a founder and innovator with laparoscopic surgery as chairman, is that part of your formula choosing going to OHSU, or am I thinking wrong? I hope
You're absolutely right. Like there's definitely support from John Hunter. He was the CEO at the time of my recruitment. The chair was Ken Ausro, who just happened to be a pediatric surgeon as well. And so it was actually his vision back in 2020, or even earlier than that, to build a fetal center. And so for me, I got really lucky because that vision really carried from the top down, from like the CEO to the department chair. And down to us. So it was a lot of support from the leadership to do this. And definitely, I've gotten a lot of support for innovating. You have discussed future indications for doing that severe care robotically. I think it's just a matter of time before we do that.
Really enjoyed your talk, Dr. Sun. It was really informative and great to hear. A question about many fetal centers, right? So in my past, I served on the American Board of Surgery. We had many discussions about too many pediatric surgical training programs. And that conversation has gone on and on. Went from 15 to 20 to now almost 50 or close to it. And then you're now reporting a very low incidence in 3 diagnoses. Is it worth it to have so many fetal training centers? Are you diluting the experience? What are your thoughts there about more fetal centers coming online?
Yeah, absolutely. I struggle with that a little bit. But at the same time, the patient population that we serve in the Pacific Northwest, if we didn't offer that, they would have to have means to be able to travel to another state. And for us, most of them will travel either to LA or Houston. And so, the patient population, sometimes they don't have the means of social support to be able to relocate, to be able to leave their, whatever children they have currently, to be able to relocate for not only the procedure, but potentially after the procedure and to delivery, and potentially if they're going to be in the NICU for months and months, they're going to stay there. And so if they don't have that means to be able to do that, then they're going to do the procedure. That's not really equitable either. So that's where I sort of justify having a fetal center in the Pacific Northwest to offer that to those that don't have to now travel far distances to another state to be able to get those services.
That's certainly a compelling argument, right? And it's a good one for the insurance companies because babies born with spina bifida, for example, or lifetime care, if you can accomplish what you've accomplished with the baby, getting more bowel and bladder function, more motor function. It's less cost to an insurance company, so it's a compelling argument.
Yeah, and in the pediatric surgery world, we're, like I said, in business for diseases, it will take a lifelong career to actually be an expert at general knowledge surgery. So it's not like any other field of general surgery that maybe after a few years, you'll do that. It just takes a long.
Well said. Thank you.
Raphael, I love your comments about mentorship, and I met Brad when I was a third-year student in Cincinnati when he was a junior fellow, and Alan Flake there, starting in the initial few programs and stuff.
Let's say you're old.
It does, yeah, correct. My gray hair does too. But it's just amazing how many lives and careers he's touched throughout his career, and it's an entire interdigitation of it. So it's wonderful. That part.
I'm Sarah Werneman. I'm actually a maternal fetal medicine specialist, so thank you for your talk today. I'm kind of curious when you think about kind of crossing what seems psychologically like a big divide. How do you kind of think about approaching that and working well with maternal fetal medicine specialists in terms of that
So
integration of clinic?
For me, like it's been wonderful. So my partner, his name is Andrew John. He's trained to watch, right? So when we got on the phone and talked to each other, we were both junior faculty. Like we've been out from fellowship like a year, and we were like really excited, really energetic. But we also had to understand that we both have a very similar skill set. It's not like I can do one thing, you can do another. So we made a point that there was some of these things are something together, and it's really helpful. Like those laser surgery cases are really tough. It's better to have a second set of eyes. Certainly, there's times when he's out of town or I'm out of town. We have to do it by ourselves with maybe like another of them to just have a second set of eyes. But it's very different. And so I think one thing is like make that agreement up front, and then really is I don't have a lot of ego or what you have. Your name has to be on it, or my name has to be on it. And so it really works well. I actually work. My office is actually in the MFM office, so I've gotten to know the MFMs a lot, and it's been a really good collaboration from it. But I think it has to start from the very beginning. And for us, anyways, it really goes back to, at least for us, like where does the cost center lie for fetal center? Institutions where the cost center lies with the Department of Surgery, then the Department of Surgery calls where it's at OB that OB will make all the calls, but at OHSU John Winter, we made a point with ASBRO that this cost center was going to be shared. It wasn't going to be, Department of Surgery wasn't going to just share that kind of collaboration.
Hi, my name's Michelle Rain. I'm one of the chief residents. Thank you so much for your talk. I really identified with the last point on your last slide about prioritizing your life and identifying work as work. Sometimes I hear a different message from some of the surgeons that I work with. How have you implemented that philosophy into your practice and set boundaries when you needed to?
Yeah, so to set the stage, Brad Warner, and I mentioned that he passed away a year ago at the age of 66 as he stepped down and sort of achieved. And that really hit me hard. He was really like a second father. But it really hit me hard because, he worked so hard. He was so successful. But at his celebration, no one talked really about his articles, his publications. People talked about the mentorship, the friendships, the encouragement that he gave to everyone that he influenced. And that's really what made it so impactful. And so really I try to emulate his life. I'm not going to be able to. But he was an example of really prioritizing that over his research and stuff like that, right? It shows yes, he was very successful, but he was even more successful doing the mentorship, being a friend, being a second father. And from a logistic practical standpoint, I've tailored my practice a little bit. I was talking to the colleagues here in pediatric surgery. I tailored my practice where I delay my clinic by half an hour, but I'll squeeze an extra patient in. I point to around a little bit later so that I can take kids to school. I do set boundaries, but it is very challenging because your patients still need you. And so there's a balance, but I think as long as you continue to prioritize and make that priority about it, thoughts lead to action. So as long as you're thinking about it, the actions all need to be able to tailor your life so that you can prioritize. I do think it's very important. And again, a tragic loss when you really hit it hard about prioritizing life and making the most out of relationships with your friends.
It sounded like you weren't necessarily planning on this whole program, but then it sounds like you're very intentional with it and obviously had a lot of success with it. I'm curious if you could speak a little bit more towards that intersection of something that you necessarily weren't planning on, but that ended up, sounds like, thriving and growing a lot, and how that kind of played out in your approach to it.
Yeah, so there was a lot of fear involved, really. I was like, I don't want to be a junior faculty So I looked at established food centers where there was going to be continued mentorship and things like that, but it didn't pan out. So you have to pivot. Sometimes you just have to pivot. So how I did it was I talked to the people that mentored me at Texas Children's. I said, listen, like, this is the job opportunity. What do you think? They're like very supportive. And I said, well, are you willing to proctor me from a far distance? And that may mean you can either video proctor my cases, or you can personally fly into these cases with me. And they're all very committed from the very beginning. And so I still have that relationship. So every single one of those cases that we start, I ask for partnership. And so for the Fetal, which is starting this fall, I asked the agency to have enough money to be able to fund 5 visits for my mentors to fly in and watch me do these cases. And so that makes it a little bit less scary, right? Like it's like you're there with them. And so that's kind of long-term, long-distance mentorship really allowed me to pivot to this job. And I think in life, like, you're going to have a lot of things that don't go your way, but I think you just have to figure out a way to be able to pivot and utilize the resources that you do have at the institution.
Curious, you know, in the past, early, you know, we had a lot of residents go out to San Francisco to participate in intrauterine surgery, and the word then was that when you operate, you don't get a scar. Is that something that still exists, or is there a certain period of time when the uterus can, the fetus can be operated without a scar, or do you get scars?
The healing process is definitely different. I don't study that basic science, but I know, like, several basic scientists, fetus surgeons that do study wound healing specifically in fetus, and it's very different. But you can still see a scar at the end with the myelomeningous repair. But it's pretty well healed. But it's also many weeks in utero and sutures resolved. But it's not completely scarred. They definitely have a scar. Even a tiny one, when we put in like a shunt, you can still see. So.
Thank you very much. Move on with the rest of your